to the second episode of the botiss podcast with Dr. Hassan Maghaireh. In the first episode of this podcast, we have already explored together the different types of bone grafting materials and how those bone grafting materials behave differently from a biological point of view. So we have come to the conclusion that one size doesn't fit all. A xenograft behaves differently from an allograft and behaves differently from an alloplastic grafting material. So based on the patient and based on the specific indication, it is important to choose the right combination of biomaterials in order to achieve the best possible results for the patient. Now, having talked about the different types of grafting materials, we will today continue our talk and we will start by exploring a little bit the topic of block augmentation. So Hassan, let me delve right into the first question. Hassan, where do you see the challenges of block augmentation?
100%. And that's also based on very good understanding of an important classification we had from periodontists, which is bone defect classification. If you go back to your perio basic knowledge, we know that whenever we have an infrabony defect around the tooth, we have a classification, a popular classification, which can be Threewall defect, Twowall defect, one wall or no wall defect. This classification can also be applied around dental implants. So let's say Threewall defect is basically when you put an implant into an intact socket with three wall remaining. Okay, a lot of my colleagues get confused and they think Threewall defect means missing three walls. No, Threewall defect means we have three remaining walls. And these are the mesial, the distal, and the intact labial plate. This is considered a very predictable defect to repair. All right? And then you could use particulate with confidence. Class 2, which is basically two-wall defect, and that's when you put an implant into a socket, but with missing labial wall. You've got two walls remaining, mesial and distal. And depends on the distance between the mesial and the distal walls, you can decide whether it's a predictable one for simultaneous implant placement and guided bone regeneration using particulate. You could go for a V defect, and that's very good. Or you could go for W defect, which becomes harder to manage, because then stability going to be affected, the blood supply to the particulate going to be influenced. And then class 3 will be one wall defect. And these are scenarios when you put an implant and you look to the mesial, you see good bone, but you look distally, there isn't bone. And you look labially, implant is literally exposed. And this is a time when you need to go for staged approach. You cannot go for simultaneous GBR. And the same applies to no wall defect, where the implant literally just into the palatal bone, no mesial, no distal, no labial wall. Having simultaneous GBR using particulate bone will be a bit unpredictable. So for the no wall defect and one wall defect, you have to go for a staged approach. Now, when you go for a staged approach, you have a choice. You could do this sausage technique, the popular sausage technique, as a staged approach and then come back after 6 months' time and put an implant. Or you could go for a bond block. Now, bond block technique is the one which gives you more stability, and I find it easier to achieve because of the solid shape of the bond block. Now this...
And where do you see the challenges of bone augmentation with bone blocks?
Exactly. That's a very good question. Bone blocks is like everything else in implant dentistry has developed massively in the last 10-15 years. 15 years ago, I personally used to go for autogenous blocks because, we always thought that autogenous bone is the gold standard and everything else is not going to work as good. But then if you start looking at your
And out of
patient
curiosity,
in private,
where did you harvest those autologous blocks?
yes, I was going to say that in a minute. If you go to the private practice and you start harvesting bone blocks from the ascending ramus or from the chin, or sometimes in bigger cases from the hip, and your patient comes to you for review after 1 week or 10 days, they're most likely angry patients. They're full of pain. They're full of swelling and bruising and agony. And it's easy for me to do the surgery, but dentists need to realize it's not about what you can do. It's about what your patient can tolerate. And once you start working in the private sector, you need to understand that patients do prefer things which are minimally invasive, providing they're going to be predictable. So just to give you an idea, Jacek, whenever I place an implant, I would call my patients after 1 week or 10 days to remove the stitches and check on the healing. And usually they come back smiling, everything perfect. Whenever I used to do these chin blocks or ascending ramus blocks, I would call them to see me after 3 weeks. Because after 10 days, they're still bruised, they're still annoyed, and I didn't want to see them at that time. It will take them 3 weeks to forget the pain, and some of them they won't. So what changed my practice is a trip to Philadelphia about 10 years ago. I was invited by the American Academy of Implant Dentistry to lecture for them. And I was the only one talking about xenograft and autogenous blocks. Everyone else in America at the time was using allografts. And I started to see the science behind using allograft blocks. I took it back to my practice in Leeds and I started talking to patients. And at the time, patient rejection to allograft blocks was really high because people did not like the idea of having bone from dead people. But when I started working with botiss provided me and my patients with the ideal scenario: good quality allograft blocks taken from live donors. And the moment I communicate this fact with my patients and explain to them how these, donors being screened, being tested, the uptake of these allograft blocks started to go from 5% of my patients to 95% of my patients. I still offer every single patient needing a block autogenous option, and I offer them the allograft option. And when I go through the pros and cons in an honest way of both sides, I'm telling you 95% of my patients going to the allograft option. But botiss also made it much easier for me as a clinician, because as we all know, whenever we do bone block augmentation, there are 3 challenges. The first challenge is harvesting the bone. The second challenge is fitting the new bone into the recipient site in a very precise way. And the third challenge, and which is a very important challenge, is getting soft tissue management around that bone block. So in that surgery, me as a surgeon had to go through 3 challenges, keeping my fingers crossed, hoping that the patient won't mind this long surgery. Now, the clever solutions botiss offered us as clinicians, we've got allograft. So we've got bone prepared off the shelf. So my first challenge now is dealt with. Now the second challenge, which is getting that block, which is usually square in shape, and trying to shape it and shave it and try. And then go to the donor side and try to shape that donor side and try. So a process used to take, in the best harvester, about 45 minutes, maybe half an hour if you're Speedy Gonzalez. But even then, that's extra half an hour of the flap being open, extra half an hour of pain, extra half an hour of your surgery time. Using the bone builder option made it easier for us to deal with this second challenge. Because nowadays we can send a scan of the defect to botiss, and botiss will, with your help as a clinician and with your guidance, design the ideal shape of your block, send it to the human tissue bank, and within a time frame of usually 4 weeks, get that block shaved and shaped to the perfect dimensions for that specific case. It's like a missing piece of the puzzle which will just slot in. So that 45 minutes of my time has been reduced to 45 seconds, which is amazing for my patients. So it's gonna give me a very precise fit at fraction of the trauma and fraction of the time. So that means I'm gonna have most of my surgical time to deal with the most important challenge, which is the third part, the soft tissue management. So my bone graft surgery now becomes like, okay, raise a flap very gently, soft tissue management, clean the bone, fit the block, put the screws, 5-minute job. And then go back to my very precise, careful soft tissue management. Close the flap under no tension, mylohyoid detachment for the posterior, or coronally advance for the uppers, mylohyoid detachment for the lowers, and so on. And again, when you explain this to your patients and go through this educational process, it's not a no-brainer that your patients will choose these CAD/CAM bone builder option, because it makes their surgery more predictable, more reliable, at fraction of the time and the trauma.
So just to summarize, when you have, let's say a relatively big defect where you don't want to use granular bone, you would go for a standardized Maxgraft block. And when you have a very big defect that is unevenly shaped, where it would take a very long time to shape a standardized block, there you would go for a custom-made bone builder, which is a custom-made 3D bone block. Is it right? Did I say
That's right. But even sometimes in smaller defects where you've got through and through bone loss, you have these anterior cases where you've got buccal and palatal bone loss. So to shave a standardized block is going to be very challenging. So even in these cases, CAD/CAM would be a great option. Let me tell you what I actually do with my patients. I go to the patient and I put on the table 3 options. I say, I can go to your chin or ascending ramus and shave the block. I could use a standardized block from the human tissue bank, or I could use computer-designed, computer-manufactured block. And I go through the good and bad and the price difference. And as I said, 95% of my patients will go for the allograft option. And some of my patients do value their time, do value, the fact that they want to reduce the risk. And they're happy to pay the extra to go for the CAD/CAM block. If I was a patient and my surgeon tells me, would you rather to have a 45-minute operation or a 2-hour operation? Would you rather have a procedure which, will take lots of cutting and shaving, or a procedure where it's very minimally invasive? Even if the second option is €1,000 or £1,000 more expensive, personally as Hassan, and I'm sure lots of people might share the view, will go for the expensive option if it's minimally invasive, if it's quicker operation. But ethically, we still have a duty to offer the 3 options to our patients.
Mm-hmm. Okay, let's maybe delve into the last topic of today. So we've been talking a lot about bone augmentation. Now let's talk a little bit about the topic of barrier membranes. So the ITI actually recommends the use of a barrier membrane whenever a biomaterial is being applied. what sort of barrier membranes do you usually use?
Again, that's a very good point. It is important to use barrier membrane. And that's for so many different reasons. Number one, we understand that when guided bone regeneration concept was introduced, it was introduced based on the GTR concept, which is if you have an infrabony defect around the tooth, you need to clean that defect and isolate that defect. So it's all about isolation. It's all about having a secluded space to stop bad cells, fibroblasts, coming into the defect. One of my mentors used to say, whenever there is a gap in the human body, there will be two types of cells competing to fill this gap. The lazy osteoblast and the very active fibroblast. Our job as a clinician to decide what type of cells I want in that gap. So whenever it's an infrabony defect or a defect around a dental implant, surely we would like to have osteoblasts being more active. So we have to isolate that space and have a barrier membrane stopping this or minimizing the number of fibroblasts coming into the defect. So number one, isolation. Number two, whenever we're talking about aesthetic implant dentistry and we talked about the importance of achieving that convexity, you can never achieve a convexity without having a properly stabilized barrier. So the way I do it, I'll put a barrier, I'll stabilize it with the titanium pins I get from botiss, I lift the membrane to one side, do my convexity and get the membrane stretch and another titanium pins. So, and then I will even suture that membrane later on into the palatal aspect.
And do you usually use resorbable membranes or non-resorbable membranes?
Again, we'll go back to that classification. If I'm doing simultaneous GBR, resolvable membrane is the way. If I'm going for staged approach, I will use non-resorbable membrane.
Mm-hmm. And when you use resorbable membranes, which one would you pick?
Okay, now this is where you guys made it very easy for us. What I like about botiss as a company, and I promise you my listeners, they haven't paid me to say this. What I like about them, that they are a one-stop shop. They don't interfere with my biology understanding. They don't force me to use one specific product. As we know, when it comes to resolvable membranes, there are two schools of thoughts. There is one school of thought which prefers membranes which resolve quickly. Because yes, we want to stop fibroblasts coming into the bony particles, but we also don't want to stop a good blood supply coming to the bony particles for a long time. Hence, this school of thought would prefer a membrane which resorbs within 6 to 8 weeks. And in botiss, they have Collprotect, which does that job perfectly right. There is a second school of thought which believes actually 6 to 8 weeks for bigger defects might not be good enough for the bone particles, because bone particles might need longer than 8 weeks of protection to become solid and vital. And resolving the membrane after 8 weeks will means more fibroblasts will come in when the particles are still not ready to fight these fibroblasts. Hence, we would like to have a membrane which resorbs after 5 months, for example, 20 weeks or so on. And botiss have the option of Jason. So botiss as a company comes to me as a surgeon and say, regardless what do you believe in, we have that solution for you. And this is how it should be. In the industry should support the surgeon rather than control the surgeon. And that's why, guys, I like what you offer to the market. In my practice, I personally belong to the second school of thought, where I like my membrane to last a bit longer. Hence, I only use Collprotect in very small defects, but most of my surgeries I will use Jason. Now, what's unique about Jason? Other than it's naturally cross-linked, which means it's very, it has good mechanical stability, I like the fact I can stretch it and I can suture it. I can suture my Jason membrane using 4O needle. I don't need to go 6O needle and stuff like that. And it's a very good membrane to be sutured without tearing that membrane. They have very good tearing resistance. And as I said, I genuinely understand the importance of membrane stability. I use titanium pens whenever it's possible, but even when I do my titanium pens mesially distally, I like to suture my Jason membrane into the palatal sort of undersurface of my palatal flap, and that will give me a proper isolation. So answering your question, my friend Jacek, I will choose the membrane which fits my specific case based on my biology understanding of the product I'm going to use.
Now, Hassan, botiss also has a soft tissue graft which is called Mucoderm, which is being used a lot by periodontists. You as a surgeon, would you also use that sort of soft tissue graft?
That's a very good question, Jacek, because Mucoudem, if you go and look at the structure of it, it comes from porcine dermis and it's nicely packed. So I started using Mucoudem even in my bone regeneration in so many cases. Now, one of the very good indications for Mucoudem is ridge preservation. So I've taken a tooth out, and the moment you take a tooth out, it's important to do all the cleaning of the socket, and you put your bony particle of choice into the socket. But then you have a challenge. Obviously, we have to cover that sort of socket. In the past, people used to do the coronally advanced flap, which I highly recommend avoiding, because if you do the coronally advancement flap, you're going to move all the good keratinized mucosa from the labial surface to the crest. So you're going to disturb the mucogingival line and you're going to have less attached mucosa labially. So this is a classical old style approach we will never do nowadays. The second way is to go and harvest a soft tissue graft. And it's okay, a valid way of doing it. You go usually to the retromolar area, cut a soft tissue plug, and just de-epithelize the margins and stitch that on top of your bony particle. But another very good technique, which I've been using for the last 5 years, is using a Mucoderm as my 2-in-1. What do I mean by that? I would like to use Mucoderm to bulk my soft tissue labially and also to act as a crystal plug. Because we do understand the moment we're going to take a tooth out, within the first 24 hours, we're going to have soft tissue changes. And one of these changes is going to be thinning of the labial mucosa. Therefore, it will be nice to improve the thickness. Of the labial soft tissue. So what you can do is basically tiny tunneling of the labial mucosa and of the palatal mucosa, and cut a small piece of your Mucoderm, hydrate it really well with saline, and then try to tuck your Mucoderm underneath the labial mucosa and underneath your palatal mucosa. So 1/3 of the Mucoderm is covered under the labial mucosa, 1/3 underneath the palatal, and in the middle will be a nice plug covering the socket or the ridge preservation. Mm-hmm. Now, the beauty about Mucoderm that you can leave it exposed, providing the margins are receiving good blood supply and it's well stabilized. And by doing this, not only you protecting your bony particles, but also improving the soft tissue quality at the time of the extraction. So you come to place your implant a few weeks later, everything gonna be nice and ready for you.
Mm-hmm. Now you have mentioned also the topic of autologous soft tissue grafts. How do you see Mucoderm compared to autologous soft tissue in terms of clinical performance? Do you see any differences there?
Yes. I mean, when it comes to connective tissue graft, obviously, in the world of perio surgeries, I think no one can argue the fact it's still the gold standard. It's, when it comes to bone, we know now, allograft and alloplast do the trick. But when it comes to soft tissue, yes, I still believe connective tissue grafts are the gold standards. But I also know in my private practice that harvesting connective tissue grafts can be technically demanding, can be a bit traumatic to the patient. And when you're dealing with small defects like that, Mucoderm can be very useful and very minimally invasive. Another use of Mucoderm I use, sometimes I could use my Mucoderm underneath my labial flap to increase the thickness of my mucosa, because we know the thicker the gum, the better protection for the bone underneath.
So Hassan, thank you very, very much for having participated in the botiss podcast.
Thank you very much again, Jacek, for the kind invitation. Thank you very much for the kind audience who gave us their time. And this is an invitation to everyone listening to us who would like to join us at the British Academy of Implant Restorative Dentistry in Leeds. They're most welcome. We do run series of masterclasses, and it will be a pleasure to have you with us in Leeds. Beautiful city, and hopefully we can have a mix between fun and education. Thank you so much.
So for all of our listeners, we will add also a link on the website below the podcast where you can go directly onto the website of the British Academy of Implant and Restorative Dentistry and have a look at all of those different courses that are there. So Hassan, again, thank you very, very much. And to all of our listeners, thank you for having listened and stay tuned.